So let's talk about like prevention. So first of all, like in my perspective, if like you had kids that were wetting the bed, period, right? I wouldn't put a really obviously if they're not toilet trained, you know, you don't worry about it. But if they're potty training and then every time you put them down to sleep, they're wetting the bed, I would start those kids on laxatives, just get them kind of emptied out to optimize their ability to be dry as soon as possible. And I did that with one of my daughters. She was wetting the bed. I said, you know what? She's been pooping fine, but obviously she's not pooping fine. I gave her Miralax and she was dry in a couple months and she had great sense. So and from that perspective, I wish people would understand the correlation so we could get on it early, because obviously it's a lot easier to treat if you're treating early in the development of the problem. But most of the kids, they show up to my office between the ages of 5, 6, and like even 18. And by then they've got a kind of a dilated colon. It's been full for a long time. So what we do is we use, you know, several different protocols to basically empty the rectum and keep it empty so it shrinks down. The most effective therapy we've used have been enemas. And so it's weird because I'm so used to using enemas. I don't even think about it anymore. I'm just like, that's the best way to treat this problem. It's a direct approach. But you say it to someone that's not involved in this, it puts them back a little bit. And so obviously I don't push enemas on every family if they've not tried simple measures like Miralax or X-Lax. There's basically 3 ways to empty a kid, I tell them. You could use osmotic laxatives like Miralax, which is draw water into the colon, make it easier to poop. Stimulant laxatives like X-Lax or Senna, and then bottom-up therapy, suppositories, enemas. But the
When you're
problem
looking at an enema, I'm curious, like I've heard of like coffee enemas and things like that. Like, I guess, what are you using for that type of an enema treatment? Like, what type of uh
yeah, we
substance are you
use
using?
we use readily available pediatric over-the-counter enemas. Plus, sometimes if it's too expensive, people can make their own. But the most common ingredients are either phosphate enemas, which are larger volume and can only be used once a day, so not my favorite. Just because you have to worry about phosphate levels if people overuse them. Glycerin is very common ingredient. It's very very useful, and then doxate sodium, which is basically a stool softener, surfactant that kind of allows water to get into the poop. And so yeah, I mean if you go on Amazon or Google and find pediatric enemas, there's several suppositories. Those are the main ingredients. You could make your own with salt water and add glycerin or even baby shampoo. And so we kind of tweak the protocol based on their schedule, how full they are, what the X-ray looks like. But it could be entirely possible that people could try some different protocol and get empty fast. I haven't found anything really that tells me which protocol is going to work best with each kid. I just try to
Mm.
trial and error, follow the X-rays, and kind of go to where the problems focused. But I know for sure that when we get them empty, they do better for sure.
So when we're looking at like not confronting and handling this, like what do long-term consequences look like of not handling this issue?
Yeah, I I don't. I don't want to tell people what to do, obviously, but I wish, from the mountaintop, I could say, take it seriously, because people always come to my office and they say the same story. Like, I was told I'd outgrow it. I was told I'd outgrow it. And now it's been 5 years, it's been 10 years, it's been 12 years. And so obviously if you're going to outgrow in a year, no one can predict when you outgrow it. It's better just to treat it aggressively. They say about 25% of kids wet the bed at the age of 5, and then 15% get better a year. So, we see kids that are getting ready to go to college. So what do you have? You have years, decades maybe, of wet sheets. That's stressful. You have years, decades of poor sleep, right? So affects brain development. You have years of affecting quality of life due to inability to go to camps or sleepovers or just stressors, which can't be good for anyone. And then let's say you have this poop issue and you luckily outgrow the bedwetting because for whatever reason in your population, in your genetic makeup, that reflex that we're setting off dies down faster. Then you grow up with a full colon and you don't even know it. And so then you're 30 and you have IBS, you have intermittent diarrhea and constipation because your colon's always full, it's dilated, and people put you on laxatives then, but you don't know because that's the main therapy for IBS, but it would have been a lot easier to manage much younger. So that's why I don't like to ignore bedwetting. I like to treat it aggressively and early. And I like just to, I think everyone would agree, you want to get the body back to kind of normal. People don't
Absolutely.
like using enemas or suppositories, but I try to focus on the fact that your colon is not supposed to be, 7 centimeters wide all the way down to your rectum. So